So I'm Jeffrey Smith. I'm a clinical professor of psychiatry at New York Medical College, and the recently past president of SEPI, the Society for the Exploration of Psychotherapy Integration, and owner of the website howtherapyworks.com and the Substack howtherapyworks.com.substack. And so I'm glad to be here with you this afternoon, and we're going to talk about how to mix CBT and psychodynamic therapy in a coherent way, and and do that with some confidence. Um, and the um, Maybe the secret that I'm going to share with you today is that the thing that's going to allow us to do this is that there are a couple of taboos, one that goes with CBT and the other one that goes with psychodynamic therapy. And those taboos have made it difficult to bring the two therapies together in a way that they really should have been together from the very beginning, but they haven't. And um, so um, the So overall, what I'm wanting to do here is to use an understanding of how therapy works in order to help myself and everybody else to do better therapy. Because if you know what's going on, then it's going to be much easier for you to have a sense of what to do next. And that's a very simple thing, but it's taken the 21st century to really be able to do that. Uh, so let me go back a little ways and talk about these two taboos. Um, the field of psychotherapy has been organized like the schools of Greece and the Middle Ages. That is, you had somebody who was really quite a genius and was charismatic who would establish a school and then try to attract disciples. And people came largely because of their attraction to the leader and follow that person because that's all there was to choose from. Nobody had any the theories that existed during those times were made up. They were somebody's invention that was about the best they could come up with to describe what they saw. And that really was the situation when psychotherapy became a profession somewhere around the beginning of the end of the 19th century and the beginning of the 20th century. Well, we inherit now and still have that same method of that same organization. Because if you look now, how many therapies are competing for disciples and telling you when you join them that you should use this therapy for everything and don't try to mix it up with anything else because then it'll be impure and it won't work and that's a big mistake and so on. And so there's a really strong tendency to do that. Now, every other science came to a point where they, as Thomas Kuhn calls it, they moved from the pre-paradigmatic phase to the phase of normal science, which is that they agreed on some scientific principles at the base of it, and then the different areas, different universities, and so on would set about trying through experiments to fill in the details. Well, psychotherapy hasn't done that yet. And I think the reason is that those schools are still operating like in the Middle Ages, with disciples and attracting people on bases other than the truthfulness of what they have to say. Well, finally, in the 21st century, we have enough information about how the mind processes information so that we can do better. Now we can finally have an understanding pretty closely of what's going on. So, what I'm talking from is really the infrastructure that applies to all therapies. And that infrastructure has to do with how the mind processes information, because the problems people bring to us for psychotherapy are problems that have to do with ways of responding to a situation that are maladaptive, that don't work very well anymore. Maybe they worked pretty well when they were first invented, but at this point, let's say in adulthood, they're no longer effective, and there are other ways that are better. I'll give you a really simple and very, very common example. Children aren't good at accepting things that don't go their way. Children do a really, really good job of watching out for their own development as human beings. They know that that's their job, and so when they run into some condition that's not good, like let's say a lack of support or nurturing, um, then what they they don't accept that. They just wait until they can find a source of something that was missing, and that can go on for decades and years and years and years, and finally, they find this nice therapist who looks like the person who's actually going to give me the support that I need, and that desire comes out, and that plan to eventually replace the thing that was missing. Well, what actually needs to happen, what's more effective, is eventually, with some help and some support, that person needs to come to accept that they didn't have in their early life what they really needed and and that's okay now, that there are other sources of support, there are other ways to get things done, and they've already learned many of them. So acceptance is often the substitute, it's often the replacement skill that we have to help people come to, even though their inner mind is still thinking that replacing what was missing was the way, or undoing the shortfall is what was needed. So that's an example. Well, let me go on and talk about those 2 taboos. So first I wanna talk about the one that goes with psychodynamic, therapy. You've probably all, um, learned that in psychodynamic therapy, you need to not be so engaged. You need not to gratify the desires of your client, and you need not to tell them what to do and be so active. So while CBT therapists do that all the time, especially in DBT, they teach people skills and show them how to use them and support them and help them to do that, and that works very well. But in psychodynamic therapy, you're not supposed to do that. Um, my own learning about this goes back a long, long time. Back during residency, we had a talk um, on sex therapy, and Helen Singer Kaplan, who was the leading sex therapist at the time, came to do her talk, and she described how she would give a homework assignment to a couple. In other words, telling them some behaviors to do, and then they'd come back the next week and they'd say, "Well, we didn't actually do that. Somehow we just didn't get around to it." And she would then go in to a psychodynamic exploration of why. So the proposed change in behavior generated some feelings and a reaction, which then had interesting psychodynamic significance. Well, I took note of that back then, and little by little, um, as I got out into practice, I became a rather active, engaged therapist, and then I got involved with addiction, and I learned that if you don't deal with behavior, if you don't really focus on behavior, then you're pretty much irrelevant. You're not going to help your addicted patient if you just talk about their psychodynamics and you don't get involved with behavior. So, so I come to this from a long ways back, and so um, those prohibitions, those taboos in psychodynamic therapy against really engaging with with the patient in a active way, and even talking about what things they might do that would help them to grow and develop in their therapy, are frowned upon. I had a really interesting experience a few years ago. Um, an esteemed colleague, a man whom I respected a lot, was retiring and moving away, and passed on some of his patients to me, referred them to me, and we spoke on the phone a little while later, and he admitted to me, he said, I'm really embarrassed to say that, and for some of these people, they may tell you about things that I did that were just supportive and nice, and he was embarrassed because he felt like technically he wasn't supposed to do that. That's how powerful those taboos are. That when early in your training, you really want to learn the rules of the game, you want to be the best therapist possible, and somebody tells you, "Oh, no, don't gratify the patient's wishes," um, then you're really going to internalize that, and so it becomes hard to leave those taboos behind. What I can tell you is that the literature shows that an active, engaged therapist is a better therapist in general. There's a significant amount of research that's shown that that really actually works better. And um, and and the same thing for talking about voluntary behavior change and what different behaviors um, for example, I learned in addiction that abstinence really opens up a whole lot of psychodynamic issues that you would not have known about otherwise. And the same thing with changing posture or many different ways that psychodynamic conflicts get buried in behavior. So on the other hand, if you tell your colleagues that you're going to be more active and more engaged with your patients, they may say, "Oh my gosh, well that could ruin the transference, or that can cause all kinds of problems." Well, it's true, and we'll talk a little bit about those later. Um, but the truth is that it's way, way, way more valuable to be active and engaged and manage the potential problems which are there. They're things you need to manage anyway. And so it's much more effective to and nuanced to manage the potential problems rather than to try to have a blanket prohibition to keep you from supposedly getting in trouble. Because in fact, if you go the extreme and do the blank face kind of tradition, then that's going to generate a tremendous reaction on the part of your patients, and that's not neutral at all. Um, so, so let's talk about those a bit later. But so I'm going to argue that psychodynamic therapists need to take from PDT, from cognitive behavioral therapy, the skills that CBT and DBT therapists have developed for helping people to improve their lives and to incorporate um, um, more rational kinds of thinking, because those really are important and they're helpful in psychotherapy. So now let's talk about the other taboo, because CBT has its own taboo. Way back when Watson pretty much invented behaviorism, he was a pretty creative guy. He also, after his career as a psychologist, he also was the inventor of scientific advertising. But in any case, um, Watson said that introspection and anything that came from within the mind was subjective, could not be measured, and was not scientific, and therefore should be left out of any discussion, any academic discussion of psychology. Well, that casts a long shadow today, that prohibition. If you look at the psychology literature, it still is very hard to find any direct reference to the specifics of patients' mental contents, uh, even in spite of the fact that cognitive behavioral therapy was a huge revolution against behaviorism. Cognitive behavioral therapy said that actually the meaning of things to people, the way their mind interprets what they um, 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 what they experience is vitally important, and it's important to understanding them. But what's happened is in the desire to be scientific, what happens is that the specifics, the nuanced specifics of a given patient are lost. And let's say the the CBT formulation, even though formulation has gained some respectability lately, the formulation typically is going to be, well, the patient is afraid of success, or they have an irrational belief that being passive is a safer thing to do. Those are general. And one thing we've learned from psychodynamic therapy is that the more we get into the specifics, the better it is for the relationship and for the results. And so I think that cognitive behavioral therapists will do very well to incorporate from their CBT, from their psychodynamic colleagues, an interest in the specifics of the non-conscious mind and how it operates and what it's actually thinking. Um, I uh, just today had some exploration of these things. Let's see. Uh, um, I'll give you a different example of that. Um, not a patient was complaining of depression and was very worried. Was a rather obsessive person. Was rather worried that he wasn't feeling loving feelings for his wife anymore, and he wondered if maybe it was too late for their marriage, and maybe it's time to go to the lawyers and get a divorce and so on. And on understanding that person, it what came clear was that for his entire life, he had been very, very afraid of having any kind of close interaction, any kind of controversial conversation with another person, and that had been troublesome for him, in professional ways as well as personally. And in the marriage, there had been very little kind of discussion. If there was any difference of opinion, they'd both go off in their corners and do their own thing, and not really try to come to any compromise or meeting of the minds or anything like that. Um, so this was a consultation, and the CBT therapist who was involved in that case was very helpful. She said to him, "When you get a thought that your marriage is over, the thing to do is to think, well, that's a powerful thought, and then not elaborate on it and not go any further with it." Well, I think that psychodynamic therapy can do better, because what we can do is we can say, that's a place where the inner mind is trying to, since it is survival oriented, it's trying to protect him by protecting him from getting engaged with his wife in any kind of real discussion. And so it's trying to bypass that by telling him that it's too late, it's already over, you're never going to go anywhere with this marriage. And I think, for to be able to understand, for the patient to understand that it's a lot more valuable to understand, to appreciate that your inner mind is trying to save you. It's trying to do something helpful that happens to be maladaptive and needs to be replaced by something new. Well, what's the new thing? The new thing is learning the skills of having an intimate, um, um, po- potentially conflictual conversation with one's wife. That's how a relationship gets built. And so, but this is a person who didn't have those skills. And so the CBT um, um, skills of teaching people about new behaviors are really valuable here. If we did the traditional psychodynamic thing and just sat back and talked about the conflict, but didn't give this person any help in figuring out how to develop the skill of having difficult conversations, then it just wouldn't happen. And eventually the marriage would come apart, and that would be an unfortunate outcome. So, so I hope this gives the beginning of a sense of how if we can let go of those taboos, if we can leave them behind, then we'll be doing ourselves and our patients a favor, and we can not ignore the potential dangers of those things, but we can certainly leave behind those traditions. One thing that I like to point out is that the prohibitions, especially those ones with psychodynamic therapy to not really engage with the patient, they come from the same place as those orphanages in England that Bowlby talked about, the orphanages that tried very carefully to maintain excellent hygiene, but no encouragement of any kind of attachment or relationship between the orphans and the people who cared for them. And that's the same Victorian atmosphere that produced the original idea of psychoanalysis that the analyst should be a blank slate and should not disclose anything or let the patient have any sense of what their feelings were. Um, and since then we know better, but the old prohibition, the old taboo, still casts a long shadow. Only recently, um, um, let's see if I think I have it. I wrote it down here. Glenn Gabbard, who's written extensively on psychodynamic therapy, wrote a paper in I think it's 2022, and he called it uh, something about the end of neutrality, that it's time to leave it behind. So but still, how many people have learned, psychodynamic therapy in an atmosphere of restraint and holding back and feeling uncomfortable about doing anything nice for a patient or teaching them something? It's time to leave those things behind. So I'm gonna stop for a minute and see if you have any questions or any thoughts, and then I'm going to talk a little bit more about the infrastructure in general of psychotherapy that forms the basis of this, and finally, I'm gonna talk about how to put these ideas into practice. So I'm gonna watch the chat right now. All right. Well, I would love you all to subscribe to my Substack. The worst that'll happen is you'll get a message every once in a while in your email, but I'm not. It won't be offensive. Um, how does one end neutrality? Um, so that we will talk about that, but first I'm gonna give you a framework to make sense out of what's going on, and then we'll talk about how to implement this, and I will answer that question. Thank you. Moment by moment, yes, exactly. I hear you. So So to just briefly, and this is outlined in other places, in a post on Substack called "Modernizing Psychotherapy," is one place that you'll see on my Substack right away, and that will give you some more detail about this. But in a big picture way, the first thing that we need in looking at the infrastructure that belongs both to psychodynamic therapy and to CBT and every other therapy for that matter is what it is we're treating. Every therapy has a different definition of what they treat, which has created all kinds of complication unnecessarily. So a group of us at SEPI, the Society for the Exploration of Psychotherapy Integration, came up with the term um, 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 entrenched maladaptive patterns. And that describes all of the problems that psychotherapy is designed to treat. Psychotherapy does some other things, but those are kind of side effects. They're knock-on effects. The things that therapy is really designed for is to change the way the mind processes information. And so that's the point of view that where we're going to find what the fact that all therapies do the same few things. So entrenched maladaptive patterns applies to to anxious or attachment patterns or character disorders or to um, all kinds of dysfunctional ways that people react, including emotions and impulses and thoughts that they have. And so entrenched maladaptive patterns is a good way to think about what all therapies try to do. And probably the gold standard there is um, one might call transformative therapy. In other words, the kind where something changes in the person that that makes them different from that day on, and that doesn't require repetitive therapies or reinforcement to keep it going, but just goes on by itself. Well, it turns out um, that those responses, those maladaptive responses, if you think about it, work in the following way. The mind takes in all kinds of information from the current circumstances, internal and external, and it takes all of that vast amount of information and and compares it to past experience and and comes up with a response, especially if this new situation is one that the mind identifies as potentially threatening, potentially a problem. And so we have a very large, very rapid, constantly operating system to take in information and to produce responses. Well, in cases where there are responses that are um, uh, maladaptive, essentially all the time, the situation is that there was an original challenge, often in childhood, but sometimes in adulthood as well as in PTSD, um, some kind of a challenge of pretty close to existential proportions, something that was really a major deal. And at those times, then the mind comes up with its best solution. And what happens then, here's where the entrenched comes in. Those solutions are resistant to change. I call them frozen in time. They stay the way they were originally invented, and the mind works really hard to keep them from changing. Why is that? Well, it just makes sense. And I don't think there's any proof for this, but it does make such good sense, and it really is useful in clinically, that the mind regards a solution to a problem as as safety equipment, and it doesn't want to change or to lose that safety equipment, and so it holds on to those things. How does it hold on? How does the inner mind hold on to those? Well, it treats any attempt to change a a response pattern, as a protective response pattern, as a threat. And it uses the same repertoire of techniques as it uses for other threats to protect those things from changing. So, one of the jobs of therapy is to work with and work through that entrenchment, work through layers of protection against changing something that's even deeper as a protective maladaptive response. And that's why therapy is a lot of work. Um, and where are this is this information processing located? Well, I'm going to tell you that the main place where it's located is in subcortical brain structures. The amygdala is one of those that's involved with fear in particular. There are other neurotransmitters, other structures involved. Um, but the important part is that the units of logic, the kind of nodes of logic that come up with a response that's less than satisfactory, we call them schemas. And fortunately, schemas are a concept that exists in CBT and it exists in psychodynamic therapy as well as schema therapy and a whole lot of different places. But we can think of schemas as located in the subcortical brain and operating for purposes of protection, of survival. And those schemas, fortunately, uh, um, um, they're They also involve a rather simple kind of if-then logic, but with many, many, many inputs. But the schema ultimately says, if this situation exists, then this is how we have to respond. And that's why we have repetitive responses. We talk about people who've had trauma being triggered. Well, the triggering means that the circumstances have come close enough to some old situation that they've triggered the old response, and it comes back involuntarily outside of consciousness. It just happens. Um, those things also, those non-conscious responses, also involve ways that the inner mind tries to and is very effective at influencing consciousness. How does it do that? It does it by projecting automatic thoughts into our consciousness, feelings into our awareness, and impulses, and also impulses to not do something. Um, we've all experienced that. We've all experienced that there are things that we don't want to do, and somehow we just don't do them. We just have an impulse not to. So whenever we think about impulses, we need to think about both impulses to do something and impulses to avoid something, not do something. So that's how the inner mind works to influence the conscious actions. That example I gave of the man who was afraid of having real heavy duty conversations with his wife was another example of the inner mind influencing consciousness by producing automatic and in this case obsessive thoughts. And of course, there's biology to that, there's genetics to it, but that's not what psychotherapy is so concerned with. We're concerned with, can we change the programming in those schemas? Well, it turns out that the field um, of the learned fear paradigm has been a subject of experimentation for quite a few years now, and now it's well known that there are just two mechanisms by which that the functioning of those schemas can be changed. One of them is called extinction, and that was described by Pavlov. And extinction has pretty much the same requirements as the other method. The only problem with extinction is it tends to be temporary because it doesn't turn off the alarm signal in the inner mind that indicates there's a need for a response. The other one is memory reconsolidation, which was only really elucidated around the turn of the 21st century. Um, and that mechanism allows reprogramming of schemas. Reprogramming with what information? Well, the information needs to come from something that disconfirms the old understanding of things that's existed in the inner mind in non-conscious form. That disconfirming information needs to be delivered to the non-conscious mind, and that's a tricky part of it we'll talk about as we go forward. But interestingly, it both triggers the possibility of rewriting the schema, and it supplies the information with which the schema gets rewritten. So does both things. So those the two requirements for memory reconsolidation and for extinction are activation, meaning neurological activation of the old schema, and the delivery of disconfirming information. And if you think about it a little bit, every therapy has different ways to activate uh, those old patterns, and we know that because when we see affect, we know we've activated something. And the other one is delivering new information. That's a part of every therapy. So um, so those are the requirements for change mechanisms. So now we know what it is we need to change. We need to change those nodes of logic, and we know how we know the mechanisms of change, um, and we know about the problems, and we know about the fact that they tend to be entrenched, and we can expect some resistance against change, even if it's positive. So I'm going to stop for a moment again and ask you if you're with me and if there are any questions. Okay. All right. So now let's talk about how do we actually do this? Good. I'm going to say two things here. Um, the first one is I'm going to tell you that there's if there's one thing I could say, which is it's what I do, and I think it's a way to really simplify what we do in therapy, so that you can keep it in mind as you're sitting with your patients, and that is seeking accurate empathy. And accurate empathy, I define that as an emotionally engaged, constantly deepening understanding of the other person's mind. Um, and so if we practice seeking accurate empathy and always trying to get deeper and a more profound understanding of that other person, then that will do lots and lots of good things for the therapy. That is pretty much almost all we have to do. So the second thing I'm going to do is I'm going to tell you about five clinical objectives, five things that we want to do and that at any given moment in a therapy, things that we are doing. Um, and so let me give you this list of five things. And what I'm going to do is I'm also going to, after this talk, I'm going to do a post and I'll make that available. It'll be written, and so it's going to be kind of a summary of the things that we're talking about. Um, so the first one is we want to make sense of what's going on, and that's what we're using our understanding, of how, especially how children respond to things, how children react, how do they protect themselves. Um, I how literal they are, because the inner mind thinks quite literally, and it often is thinking like a child, and we can sometimes tell what age we're looking at. At what age was a particular response frozen in time? Because the style of what children are concerned about is different. So making sense of things is number one. Number two is new learning. And that's where the need to pay attention to behavior is so important. Um, you can imagine, so as in the example of the guy in the with the marital issues, um, there's a need to practice and to learn new skills. And when people first do something that they haven't done before, like let's say being assertive, um, they're going to make a muck of it. They're not going to do a very good job, because they don't have any experience. And so we need to help our clients expect to be awkward the first times they try something, and we need to help them be prepared for that. The results may not always be as great as they hope, and maybe we need to help them have the idea of taking small risks before they take big ones. So there's a lot to it, and I think that, that's a place where I'm, more like a coach probably than a psychodynamically oriented therapist, even though I'm very much thinking about why this is there and what survival function it's promoting. But I'm also thinking about new behaviors. Why? Well, experience is one of the best ways to communicate with the nonverbal inner mind. So one of the best forms of disconfirming information is new experience, is trying something out, knowing that it's different and that it's new. That has a very powerful way of sending a message to the inner mind that that frozen response is not the only one, and that maybe there are better ways to handle a given situation. Um, so we're really entering into a dialogue with a non-conscious and invisible dialogue with a non-conscious part of the mind, and that may seem silly, but it actually is critically important. So sometimes we do it verbally, sometimes we do it we communicate with our tone of voice or gestures, or even the soft pillows in the office give are sending messages. Um, so um, so new learning is critically important, because if we're going to substitute a different pattern of response, that's it's going to have to become part of the person's instinctive repertoire and be available to their non-conscious mind to put this into action. So new learning is the second of the tasks of the clinical objectives that we're going to pay attention to. The third one is building trust. Now I can tell you why common factors are important, because common factors boil down to trust in the relationship and the process. And so what I can tell you now is that the function of that trusting relationship is to help overcome entrenchment. Is when the inner mind, like a child who's reluctant to try something, I'm scared. I'm too scared to go on the roller coaster. I don't think I want to do that, or something like that. Or we need what motivates the inner mind to do things that are new and different is a sense of confidence. And where do they get that confidence from? A trusting relationship. So the trust is extremely important in helping people get over um, their reluctance and their internal non-voluntary resistance to healthier behaviors. The relationship also, by the way, common factors, does something else. It often provides disconfirming information, because when the relationship with the therapist turns out, when the person is expecting one thing, like, "Oh, you're gonna throw me out of treatment because you'll be so disgusted by what I'm about to tell you," um, and then you don't throw them out of treatment, that sends a new message, a disconfirming message to the inner mind, and that's part of that process of um, um, of memory reconsolidation that leads to permanent change in the schemas that produce the old maladaptive responses. Um, so, so that's the third of the five clinical um, um, objectives, and the fourth one and the fifth one are the two requirements for memory reconsolidation. The fourth one is activating the old pattern, and there are many ways to do that. We do it just by conversation, by exploration, and also over the course of time in a relationship with the client. Pretty soon, patterns begin to emerge in that relationship, and those become a source of disconfirming information. Look what's going on. Let's take a look at this. Is there another way that this could take place? Um, what's happening here? And then the number five is delivery of that new disconfirming information to the inner mind. And the reason I say delivery is because it's so important that we speak in ways that the non-conscious, nonverbal mind can understand. And that's where a tone of voice may be way more communicative than the things that we say. Um, and so we need to use our intuition and our empathy to come up with to use our own non-conscious mind to come up with ways of expressing something that are going to be meaningful to our client, and ways of listening to them and using their own information to understand them better. So in doing these five things, I think you can begin to see that seeking accurate empathy does a lot. It takes care of a lot of them. Seeking accurate empathy is a good way to make sense of what's going on. It's a way to build trust, because people all want to be understood, and so the better we understand them, the more trust we're going to get. It's a way of activating the old maladaptive fears and worries and concerns that come up, and finally, it's a way of delivering new information and experiences that are going to be taken in by the inner mind. The only thing that goes a little beyond accurate empathy is helping people with new behaviors. And I'm going to point out here that that is actually super important in a particular way. Arrested development is one of the things that we see most often in our clients in therapy. And nowadays, adulthood begins around age 35 or something like that. Um, frequently, and so what helps somebody to develop, what helps people mature? Well, it's having experiences, it's having, significant, emotionally engaged experiences that teaches us new skills and new abilities and fills out our emotional development. Well, the way that happens is by trying things out, and the way it's arrested is by blocking off areas and not gaining experience in those areas. And so I'd say about 50% of what I do as a therapist is helping people with growth and maturation, helping people try out new experiences and learn from them. So it's a very, very important part of therapy that goes a little bit beyond accurate empathy and just understanding. It's the building part. So I hope at this point that I've been as clear as I can that that for psychodynamically trained therapists, they need to learn something from CBT and DBT about how people learn skills, and the CBT and DBT therapists could refine their effectiveness and be by being specific about learning about seeking accurate empathy and learning the specific um, um, to understand the specifics of each individual person, how that both enhances the relationship and also creates the conditions for memory reconsolidation to take place. Even if you don't think it's taking place, it probably is. So I'm going to stop here and ask for questions, um, and let's see what comes on the chat. I'm going to do something, a couple of things about this. So I'm planning to do this on a weekly basis. This is fun for me. Um, yep. Yep, acceptance is so difficult. You're absolutely right. Exactly. And a trusting relationship is probably more important in setting the stage for acceptance than anything else. Um, how to foster acceptance? It happens when people actually consciously admit to themselves that what they had hoped to do is not going to happen. And that is painful. And so we need to sit with them through the pain, um, and and help them have hope and belief that this is actually going to be better on the other side, that acceptance actually makes life better. Um, um, so something I've done lately with people who are having trouble with behavior change is to ask them to find an avatar, to find a role model that they look up to and who they would like to be like. Because I think that's one of the imitation is one of the important ways that we can learn new behaviors and incorporate those as part of our repertoire. Not doing enough when you're coaching. Well, as you understand those change processes, the learning and the memory reconsolidation and the extinction, I think you'll be aware that just sitting with somebody and being connected empathically, and if there's something you don't know, then asking about it. Those are the ways that you take things deeper and to learn to have confidence that that actually is therapeutic. So what I would add to OCD, I think that the CBT approaches to OCD are pretty good. What I'd add to that though is if you can explain to the person and kind of help them come to respect and even love their inner mind, in love the child inside, and and see that those obsessive thoughts or behaviors as solutions to a problem, as the inner mind trying to solve something, trying to get you ready for the calamity that's liable to happen any moment now, or trying to um, uh, uh, to get rid of the angry pressure that makes you want to do something destructive. And so I think that understanding of the function and respect for the inner mind for producing those kinds of things is very helpful. People's quick typical reaction to learning that their inner mind has different ideas and different solutions to problems than their conscious mind is that they wanna get rid of that nasty kid, and it's very important to, help them understand that you don't change wayward children by being angry and hurtful, you change them by understanding and empathizing with them. Um, about neutrality, well, I'll just tell you this, the earliest example, um, so I don't forget, I do wanna say, so this is gonna be a weekly thing. I'll be happy to chat with you, and I would really like to respond to the questions and concerns and interests people have. So the next time the invitation is going to go out, it's the second question about what would you like to have discussed is going to be a requirement. I'm going to ask for that. So now to go back and to answer the first experience I had of um, memory reconsolidation was an experience of catharsis. A patient who had dissociative identity disorder disclosed her worst trauma, or one of her worst traumas, after about 4 years of hard psychotherapy, hard work, dealing mostly with anger. When it finally came out, it took about a couple of long, prolonged sessions of more than an hour sessions, where she told me about different facets of what had happened, and and, and she the horror she had about those things that had kept them covered up for years and years and years disappeared. They were unpleasant memories, but that was it. They didn't generate the same kinds of responses that they used to. And so I was trying to make sense out of this, and nobody taught me anything about trauma in those days. So I went back to early Freud, and Freud said, this is where Freud came to understand about making the unconscious conscious. But Freud missed one part because he thought, being a Victorian, that the therapist is a neutral observer and doesn't have any influence on the process. And I knew at that point, it was clear to me that just my presence and my understanding were providing disconfirming information. They were they the message from my being there and not freaking out was that this was a terrible, awful thing that happened to you. I'm so sorry. But it's over. It's done now, and it's never gonna happen again. And that message was new. So so that was how, just being there and saying a word here or there, not any big explanations or anything, was enough to convey that new information. So neutrality is an attempt to avoid, um, um, taking sides. Yes, there's danger in taking sides. Sometimes you can be overbearing or infantilize, and so we do have to manage that and be aware of it, especially if we have, rescue fantasies and that kind of thing. Um, but those are things to manage, and one way to do it, probably the most important, is if you find yourself being pushy about something, then you have to own it. You have to admit that, yes, I do have an investment in that, and that will go a long ways towards repairing a potential rupture in the relationship and getting you on the same wavelength. Um, and uh, that's where accurate empathy comes in very, very handy because it's really a collaborative process. Um, I had a second session with somebody very recently, and we at the end of that time, we came out together with a really good understanding of what had happened in the past and how it was influencing the present and what we needed to do. It's when you actively go after understanding, they're quite happy, and when you're a promoter of anything that's going to help the person feel better and do better, then, that's fine unless it's something that's where you're where you're misattuned, where you're missing the boat and you're on a different wavelength from the patient. And then we need to be monitoring the relationship well enough and closely enough to become aware of that we're not on the same wavelength. And then we have a a rupture to repair. All right, so I'm gonna say goodbye for now, and thank you for joining, and I hope you'll want to come back next time, and please give me topics, give me ideas and things that you want to have discussed, and we'll go ahead and do that. So, take care, everybody, and it's been a pleasure, and I will see you next week.